What is a CABG? Coronary artery bypass graft. So we looked at an artery, coronary artery, and we were like, no. And now we got to bypass it because it's so blocked, I can't even get like nothing in there to clean it out. Yeah? Okay. This is a giant heart surgery, right? Like we're cracking the chest. Like let's move it. Okay. So this is a big one, okay? And you can either have 1, 2, 3, 4, or 5 of them that we are bypassing, okay? Yeah, that's a big surgery. That's a big one. Yeah, at that point, just give me a new one. All right. All right. So pre-op, you're the pre-op nurse. You're going to run them up in there and you're like, let me do a full history and physical. How you doing, sir? What surgery are you here for today? Okay. Make sure you have a copy of the consent form. And then you need to explain to them what to expect afterwards. Now, what do you think this patient is going to look like when they come out of out of CABG? Right. So they're going to be intubated. They're going to have chest tubes. They're going to have an A-line. They're going to have IVs. So you need to explain to the patient when you come out, it's going to be a bad day. And then you need to tell the family that too, because they may not be expecting seeing a patient that's all hooked up to all of these tubes, right? You need to let them know, hey, we're going to crack you from here to here. So you're going to have a big giant scar and it's a thing. Yeah, this is going to be painful. Okay. All right. So you need to start 2 large bore IVs because I might need to get blood, right? Yeah. Because the risk of obviously hemorrhage is probably pretty high with CABG, and the risk of clotting is also very high because you got to stop the heart. It's kind of hard to surgery on it when it's speeding. Yeah. Okay. All right. So you need to start an art line because what am I getting an art line for? Blood pressure and ABGs, okay? They need to be NPO for 12 hours prior to the procedure. That is a non-negotiable, okay? Because this is a big one. Obviously, we need vital signs. We need their weight for medications, and we need to check their blood sugar to try to get that under control. Because when they go into surgery, what will happen to their blood sugar? It's going to really increase because they're under massive stress. I said dumb, but I'm in a... Okay. Pre-surgery shave prep. So again, I'm going to shave their chest and then, we're going to clean it with like, some chlorhexidine or something because we're about to cut the whole damn thing open. I'm going to run some labs because these labs may tell us we ain't getting surgery today. Yeah. All right. I'm going to do a CBC. What in the CBC would tell me not today, Junia? All right. If they have a very high white blood cell count, do you want to do an open heart surgery on someone who already has an infection? Not today. Okay. What else could be in there where we're like, what if their hemoglobin was 6? Do you want to start? No. So we would give a blood transfusion first, and then we'll try again tomorrow. Okay. All right. I'm going to do some coags because they have 2 risks during CABG. Well, they have more than that, but 2 big blood related. Bleeding and clotting, right? And they can go into DIC, can't they? Oh, no. So I need to start my coags and see where we're at. I need a BUN and creatinine. I need to know kidney function because... Oh, okay. That's all y'all know. Okay, cool. You're about to give them lots of fluids, right? Their kidneys are about to go under something, right? Because you have to do bypass for the bypass. What do I mean by that? You put them on a bypass machine to do the bypass, right? So you're going to stop their heart, and that is the machine that goes through and it oxygenates your blood. So you need to make sure that kidneys are good because you're basically about to do full body dialysis on this patient, right? Okay. We need a CMP, which BUN and creatinine should be included in that, right? We need a type and cross because they could hemorrhage. Yeah. LFTs, which of course is also included in CMP. We do an MRSA swab. Y'all know we do all these on patients every week at the hospital, right? Every hospital has a different day that you do an MRSA swab, right? Because if they're colonized with MRSA, do you want to do an open heart surgery? No, I'm going to have to treat them. It's in their nose usually. Now hospitals are trying to go to rectum, but I'm like, we ain't doing that once a week. Like, I don't know. They're real obsessed with the butt. Like when COVID was first coming out, they were trying to do rectal swabs, and people were like, I'd rather you stick it in my brain than stick it like up my bum. They're weird, right? I'm like, nah, y'all. Because y'all know they said for a long time COVID was coming out in the stool, and that's how it was being transmitted to everybody because it was going through the sewer system or what have you. I don't know. This has been such a weird 3 years. Okay. Chest x-ray and EKG. Obvi, because I need to see the heart before I go in and operate on it. Cool.
This is images, right?
Yes. All right, so we go in there, and the issues that you may deal with right when you are post-op. So y'all remember post-op nursing is different than everything else. because things that would be really abnormal on a floor are normal in post-op. Like they're going to come out and have a temperature of 95. And we're not going to be like, I was like, here's the blanket, sir. Right? They're going to come out with a very low blood pressure usually because, you know, we've got bleeding and stuff. I'm going to bolus them. Yeah. They're going to come out with an altered GCS, altered neurostatus, because you just doped them up for hours at a time, right? So an altered GCS would be normal post-op, right? What is the one assessment post-op that is your giant red flag where if you see this, you're like, oh, no. Oh, no, but you were really close. Just use the first word. Oh, muscle rigidity. That is always your red flag. If you're a post-op nurse and you see muscle rigidity in your patient, what does that mean? Where'd your brain go, man? All right. What does that tell me? They just had surgery and now they are rigid. They just had anesthesia and now they're rigid. Oh. Yeah, whatever person going. Can we form the words and try? I know y'all know what I'm talking about. Thank you. There it went. It is malignant hyperthermia, where they get very high temperature, they get muscle rigidity, heart rate's high, everything's high, right? That is a genetic reaction to anesthesia, and it is a giant red flag, and you have to treat it or they will die. Okay. That's just neither here nor there. That was just a fun fact I gave you. Okay. So post-op issues, hypothermia, they're going to come back very cold, right? They've been in a freezing cold room for hours and hours at a time. They obviously are at risk of bleeding and clotting. Dysrhythmias, because yeah, you operated on the heart. Okay. Anemia. What do you think the blood loss is during that kind of surgery? Right. And then of course infection, but that's like way post-op. If they just tell you a patient just came post-op, do not freaking pick infection. You can't get infected in 20 minutes. No. Don't pick it. They're going to want usually a bleeding or a clotting issue. Okay. All right. Okay, so after surgery, you're going to the ICU. You will have 2 chest tubes. You will have 2 large bore IVs. You will have an ET tube in your mouth. You'll have an art line, and you'll have on TED hose and SCDs. Good luck, ICU nurse. Okay. All right, so post-op, you get this patient. First thing you need to do, put them on your monitors, right? Because you're getting transferred. You got it. Okay. You need to do intubation and ventilation care, which I'm assuming y'all know what to do. Oral care with chlorhexidine. Yeah, there's a chlorhexidine mouthwash. Yeah, don't just do the regular one because that would be gross. Yeah, chlorhexidine mouthwash. We clean it out to prevent pneumonia, right? How do you position this patient? 30 to 45 degrees, okay? Because they just came out of surgery. We need them upright. They can't breathe very good, right? Probably a lot of fluid, okay? They got stuff all over them, right? So we're going to set them 30 to 45 degrees. They're vented, so you need to make sure you're cleaning out their mouth. Suction only as needed, right? We don't suction on a schedule because every time you open that suction, they're at risk of infection, right? Right. Okay. What's the best way to prevent infection post CABG? Good hand washing. Where this side of the table at? Y'all just look at me like I could not tell you. Oh, don't quit picking it. Keep going. Keep going. All right. I've got an NG tube to suction. Why did this patient need an NG tube to suction? Okay. They were NPO, which means okay, but what? But lots of people are NPO without an NG tube. Is this a big surgery or a little surgery? Big surgery. Don't you think they're producing massive amounts of cortisol? What's function number 11 of cortisol? Increases acid. So this patient's going to get a ulcer if you don't put in an NG tube to suction. Are y'all with me? Okay, it seems like our processing time has significantly slowed. Okay. All right, we got them on ABGs. We got them on, you got to watch the chest tube. Y'all know where to put the chest tube. You tape it to the floor, yes? Okay, it's taped to the floor. It is taped to the floor. Because if somebody knocks it over, you won't pull it right out. Okay, so it needs to be taped to the floor, dependent below the patient, just like a Foley. Okay, you with? Okay. All right. What happens, by the way, if the chest tube comes out of the patient? What's the first thing you're going to do? Cover it with what? 3-sided petroleum gauze dressing. Okay. What do you do if the tube comes out of the unit? You're going to put it in a cup of normal saline. And then, help. Okay.
What do you mean?
You put it in a cup of normal saline.
Where did it come out of?
The chest tube unit.
Like the thing on the floor? Yeah.
Yeah, because that's connected to your patient. Yes?
So you
Okay.
put it in saline so that way air's not going through.
Yes,
Okay.
until you can get a new chest tube unit, right? Okay. What if somebody kicks over the chest tube and the top opened?
Same thing.
You have to redo well, yes, you would do the same thing, but you'd have to redo the entire unit because it was supposed to be sterile, and now it not. Okay. What would happen if all of a sudden you note that there is no chest tube drainage coming out, and they just had a CABG? You know they're supposed to be.
Yeah.
What's the first thing you should do?
Check the line.
Let's auscultate the patient first, and if I'm like, oh, there's no breath sounds, then I'm whoopsies. Okay, but if I'm like, okay, something's happening, the second thing you're going to do is just to reposition the patient. Sometimes it's just sitting on the chest wall or something. And if you go like this and just turn him a little bit, it's going to go and just come on out. Okay. What if you see bubbling in the water seal chamber?
Bubbling in the water seal chamber.
Seal, water seal. That would mean a leak. If you have anything that's sealed and you see bubbles in it, what would you think? There's leaking, right? Okay, so I got to go find the leak in the tube. Yes? Okay, in the water seal chamber, all you should see is tidling of the water. It should go up with when they breathe in and breathe out. Okay, so what's supposed to be in the water seal chamber? Gentle tidling. Up, breathing in, breathing out, breathing in, breathing out. Should you see bubbles in a sealed chamber? No. If you see bubbles, that means an air leak.
What is this thing?
Okay. A chest tube.
I have no idea what you're talking about.
Y'all have never heard of a chest tube?
I mean, I've heard of a chest tube. I've never seen anything like it. You're saying like water seal? I'm like, I don't know what you're talking about.
Yeah, hold on. There's like 3 water seal with chamber. I only know because I've seen it over this section.
Sorry, I'm in utter and complete shock. Okay, so I am going to get y'all in a video of the full chest tube because you're going to need much more than what I'm telling you now. Okay, so write that down to remind me. Somebody tell me at the end to send y'all the chest tube video. It's from pediatrics, but it doesn't really matter. Okay. Okay, that's like an adult one concept that I thought everybody would have known. Okay, all
I
right.
mean, like you say a chest tube, I'm assuming like, you know, there's from, you know, Grey's Anatomy, you see the tube, but I don't know anything about like fluid and seals and.
Yeah.
Okay. I mean, I've seen those on the floor.
Okay, so I'll send you. That's not even included in this module because I just. All right, so I'll send that separate. Okay. The patient needs very good oral care. What are we trying to prevent? Ventilator associated pneumonia. Okay. TED hose and SCDs. What are we trying to prevent? DVTs. Post-op antibiotics. Which one's better? Antibiotics or hand washing? If y'all don't pick hand washing on this test, I'm going to be very mad. They have an indwelling Foley only because I really need a good, accurate urine output so I can make sure that their heart's like, you know, working. Thank you. Thank you. All right. Things to monitor. We need to watch their bowel sounds. What am I expecting? When should bowel sounds return after a giant surgery? 4 hours. We should have something. Something. They should at least be like moving something. Yes. Because they're coming out of anesthesia at that time. Right? If they have absent bowel sounds, that's.
But it's normal for them to be hypoactive.
Oh, yeah, for sure. Hypoactive would be totally normal. All right, urine output. Right after a CABG, we want at least 0.5 mLs per kilo per hour. That is the minimum urine output you can have after a giant surgery. We're going to watch their potassium levels because, you know, heart. All right, watch the wound site. You know, we don't put anything on that wound site. No powders, no creams, no lotions, no nada. We just look at it. We're like, heal, please. Okay? Because it's all stapled together. Right? If it's got a bunch of junk coming out of it, which that can happen sometimes, not like pure pus, but like it can get, you know, it's got exudate. That's normal. You can use like a little bit of normal saline and a little Q-tip and kind of clean, but don't really mess with it. It'll heal on its own. Okay. All right. Blood sugar. We need to monitor their blood sugar because they just went under a massive, right? So you would expect that their blood sugar would be elevated. So even in a non-diabetic patient, they may need sliding scale insulin for a period of time. Okay. We're going to watch their blood pressure through their art line and their MAP. What's a minimum MAP? 60. We're going to watch their chest tube output. I will explain that in the video. Okay. Because there's certain protocols you have to watch for. Do either of y'all know what the chest tube output red flag is?
Per hour.
Uh-huh.
200.
More than 100 for 2 hours in a row. Okay. All right. We're going to do an H&H. We're going to keep doing those because I need to see, is this patient bleeding? Yes. And then you need to monitor their temperature. If they continue to be hypothermic, we need to warm them up. But if all of a sudden they have 101.6, oh no, who forgot to wash the hands? All right. All right, so what are you going to be doing as a nurse? Aggressive pain management. Can you imagine how freaking bad this hurts? What if you're trying to do TCDB, okay, and the patient's like, can't, it hurts. We're going to splint them because they have, I mean, I would imagine it hurts like hell. You're going to be one of those mean nurses, and I think you're going to be great. All right, we need to give peptic ulcer disease prophylaxis, okay? So what drugs would I consider giving? PPIs, which end in? Hold on, please. Prezol. We could also give H2RAs, which end in tadine, like ranitidine, whatever. Okay. We're going to put in fall precautions. We do ambulate the patient like that day or the day after because our goal is to extubate within 4 hours. Okay. Encourage TCDB ISQ1. What is that? Turn, cough, deep breathe, incentive spirometer every hour because your risk of post-op pneumonia is very high. If they're like, I can't, it hurts, we're like, here's a pillow, splint it, okay? Neurochecks Q15 because there could be, I mean, what's the first signs and symptoms of hypoxia? Y'all, I'm going to punch you all in the face. That is not even true. Remember, anytime I ask you what's a first sign and symptom, it will never be in the same like body system. Restlessness and anxiety. Restlessness and anxiety is a first sign and symptom of hypoxia. That is something you should have learned in the first day of first semester. Okay, so restlessness and anxiety we could see, right? What if the patient presents with left-sided hemiparesis? They're having a stroke, right? That could be possible after a CABG. Aren't they a high clotting status, right? Okay. Let's say the patient gets new onset confusion. They could be bleeding out. All right, so we're going to do neurochecks Q15. All right. Do you understand how to do a CABG and what your job is? Okay. I feel like y'all are like